Welcome to this video entitled Asthma. Let's begin with a definition. The National Asthma Education and Prevention Program, abbreviated as NAEPP, defines asthma as a chronic inflammatory disorder of the airways in which many cells and cellular elements play a role. In susceptible individuals, inflammation causes recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. These episodes are usually associated with airflow obstruction that is often reversible either spontaneously or with treatment. The inflammation also causes an increase in bronchial hyperresponsiveness, abbreviated as BHR, to a variety of stimuli. Next we will discuss the pathophysiology of asthma. 1. The major characteristics of asthma include a variable degree of airflow obstruction, related to bronchospasm, edema, and hypersecretion, bronchial hyperresponsiveness, and airway inflammation. 2. Inhaled allergens cause an early-phase allergic reaction characterized by activation of cells bearing allergen-specific immunoglobulin E, abbreviated as IgE, antibodies. There is rapid activation of airway mast cells and macrophages, which release pro-inflammatory mediators such as histamine and eicosanoids that induce contraction of airway smooth muscle, mucus secretion, vasodilation, and exudation of plasma in the airways. Plasma protein leakage induces a thickened, engorged, edematous airway wall and a narrowing of the airway lumen with reduced mucus clearance. 3. The late-phase inflammatory reaction occurs 6 to 9 hours after allergen provocation and involves recruitment and activation of eosinophils, T lymphocytes, basophils, neutrophils, and macrophages. 4. Eosinophils migrate to the airways and release inflammatory mediators, such as leukotrienes and granule proteins, cytotoxic mediators, and cytokines. 5. T lymphocyte activation leads to release of cytokines from type 2 T helper, abbreviated as Th2, cells that mediate allergic inflammation, interleukin, I, L4, IL5, and IL13. Conversely, type 1 T helper, abbreviated as Th1, cells produce IL-2 and interferon gamma that are essential for cellular defense mechanisms. Allergic asthmatic inflammation may result from an imbalance between Th1 and Th2 cells. 5. Mast cell degranulation in response to allergens results in release of mediators such as histamine, eosinophil, and neutrophil chemotactic factors, leukotrienes C4, D4, and E4, prostaglandins, and platelet activating factor, abbreviated as PAF. Histamine is capable of inducing smooth muscle constriction and bronchospasm and may play a role in mucosal edema and mucus secretion. 7. Alveolar macrophages release a number of inflammatory mediators, including platelet activating factor and leukotrienes B4, C4, and D4. Production of neutrophil chemotactic factor and eosinophil chemotactic factor furthers the inflammatory process. 8. Neutrophils are also a source of mediators, platelet activating factors, prostaglandins, thromboxans, and leukotrienes, that contribute to bronchial hyperresponsiveness and airway inflammation. 9. The 5-lipoxygenase pathway of arachidonic acid metabolism is responsible for production of cystenyl leukotrienes. Leukotrienes C4, D4, and E4 are released during inflammatory processes in the lung and produce bronchospasm, mucus secretion, microvascular permeability, and airway edema. 10. Bronchial epithelial cells participate in inflammation by releasing eicosanoids, peptidases, matrix proteins, cytokines, and nitric oxide. Epithelial shedding results in heightened airway responsiveness, altered permeability of the airway mucosa, depletion of epithelial-derived relaxant factors, and loss of enzymes responsible for degrading inflammatory neuropeptides. 11. The exudative inflammatory process and sloughing of epithelial cells into the airway lumen impair mucociliary transport. The bronchial glands are increased in size, and the goblet cells are increased in size and number. Expectorated mucus from patients with asthma tends to have high viscosity. 12. The airway is innervated by parasympathetic, sympathetic, and non-adrenergic inhibitory nerves. The normal resting tone of airway smooth muscle is maintained by vagal efferent activity, and bronchoconstriction can be mediated by vagal stimulation in the small bronchi. Airway smooth muscle contains non-innervated beta-2 adrenergic receptors that produce bronchodilation. The non-adrenergic, non-cholinergic nervous system in the trachea and bronchi may amplify inflammation in asthma by releasing nitric oxide. We will now consider the clinical presentation of asthma. Let's begin with chronic asthma. 1. Classic asthma is characterized by episodic dyspnea associated with wheezing, but the clinical presentation of asthma is diverse. Patients may also complain of episodes of dyspnea, chest tightness, coughing, particularly at night, wheezing, or a whistling sound when breathing. These often occur with exercise, but may occur spontaneously or in association with known allergens. 2. Signs include expiratory wheezing on auscultation, dry hacking cough, or signs of atopy, e.g., allergic rhinitis or eczema. 3. Asthma can vary from chronic daily symptoms to only intermittent symptoms. The intervals between symptoms may be days, weeks, months, or years. 4. The severity is determined by lung function, symptoms, nighttime awakenings, and interference with normal activity prior to therapy. Patients can present with mild intermittent symptoms that require no medications or only occasional use of short-acting inhaled beta-2 agonists to severe chronic asthma symptoms despite receiving multiple medications. Next we will discuss severe acute asthma. 1. Uncontrolled asthma can progress to an acute state where inflammation, airway edema, excessive mucus accumulation, and severe bronchospasm result in profound airway narrowing that is poorly responsive to usual bronchodilator therapy. 2. Patients may be anxious in acute distress and complain of severe dyspnea, shortness of breath, chest tightness, or burning. They may be able to say only a few words with each breath. Symptoms are unresponsive to usual measures. 3. Signs include expiratory and inspiratory wheezing on auscultation, dry hacking cough, tachypnea, tachycardia, pallor or cyanosis, and hyperinflated chest with intercostal and supraclavicular retractions. Breath sounds may be diminished with very severe obstruction. Next we will focus on the diagnosis of asthma. Let's begin with chronic asthma. 1. The diagnosis of asthma is made primarily by a history of recurrent episodes of coughing, wheezing, chest tightness, or shortness of breath and confirmatory spirometry. 2. The patient may have a family history of allergy or asthma or have symptoms of allergic rhinitis. A history of exercise or cold air precipitating dyspnea or increased symptoms during specific allergen seasons also suggests asthma. 3. Spirometry demonstrates obstruction, forced expiratory volume in 1 second, abbreviated as FEV1, to forced vital capacity less than 80%. with reversibility after inhaled beta-2 agonist administration. At least a 12% improvement in forced expiratory volume in 1 second. Failure of pulmonary function to improve acutely does not necessarily rule out asthma. If baseline spirometry is normal, challenge testing with exercise, histamine, or methacholine can be used to elicit bronchial hyperresponsiveness. Next we will look at acute severe asthma. 1. Peak expiratory flow, abbreviated as PEF, and FEV1 are less than 50% of normal predicted values. Pulse oximetry reveals decreased arterial oxygen and O2 saturations. The best predictor of outcome is early response to treatment as measured by improvement in FEV1 at 30 minutes after inhaled beta-2 agonists. 2. Arterial blood gases may reveal metabolic acidosis and a low PaO2. 3. The history and physical examination should be obtained while initial therapy is being provided. A history of previous asthma exacerbations, e.g., hospitalizations, or intubations, and complicating illnesses, e.g., cardiac disease, and diabetes mellitus, should be obtained. The patient should be examined to assess hydration status, use of accessory muscles of respiration, and the presence of cyanosis, pneumonia, pneumothorax, pneumomediastinum, and upper airway obstruction. A complete blood count may be appropriate for patients with fever or purulent sputum. And now we will look at the desired outcome. Let's begin with chronic asthma. The NAEPP provides the following goals for chronic asthma management. A reducing impairment as follows. 1. Prevent chronic and troublesome symptoms, e.g., coughing or breathlessness in the daytime, at night, or after exertion. 2. Require infrequent use, that is equal to or less than 2 days per week, of inhaled short-acting beta-2 agonist for quick relief of symptoms, not including prevention of exercise-induced bronchospasm, abbreviated as EIB. 3. Maintain near normal pulmonary function. 4. Maintain normal activity levels, including exercise and attendance at work or school. 5. Meet patients' and families' expectation of and satisfaction with care. B. Reducing risk as follows. 1. Prevent recurrent exacerbations and minimize the need for visits or hospitalizations. 2. Prevent loss of lung function. For children, prevent reduced lung growth. 3. Minimal or no adverse effects of therapy. We will now briefly look at acute, severe asthma. The goals of treatment include the following. 1. Correction of significant hypoxemia. 2. Rapid reversal of airway obstruction, that is within minutes. 3. Reduction of the likelihood of recurrence of severe airflow obstruction. And 4. Development of a written action plan in case of a future exacerbation. Let's now briefly look at treatment as illustrated in Figure 81, which depicts the NAEPP stepwise approach for managing chronic asthma. Figure 82 illustrates the recommended therapies for home treatment of acute asthma exacerbations. Next we will discuss non-pharmacologic therapy of asthma. 1. Patient education and the teaching of self-management skills should be the cornerstone of the treatment program. Self-management programs improve adherence to medication regimens, self-management skills, and use of healthcare services. 2. Objective measurements of airflow obstruction with a home peak flow meter may not necessarily improve patient outcomes. The NAEPP advocates use of peak expiratory flow monitoring only for patients with severe persistent asthma who have difficulty perceiving airway obstruction. 3. Avoidance of known allergenic triggers can improve symptoms, reduce medication use, and decrease bronchial hyperresponsiveness. Environmental triggers, e.g., animals, should be avoided in sensitive patients, and those who smoke should be encouraged to stop. 4. Patients with acute severe asthma should receive supplemental oxygen therapy to maintain arterial oxygen saturation above 90%, that is above 95% in pregnant women and patients with heart disease. Significant dehydration should be corrected. Urine-specific gravity may help guide therapy in young children, in whom assessment of hydration status may be difficult. Let's now progress to pharmacotherapy of asthma. We will begin with beta-2 agonists. 1. The short-acting beta-2 agonists, listed in Table 81, are the most effective bronchodilators available. Beta-2 adrenergic receptor stimulation activates adenyl cyclase, which produces an increase in intracellular cyclic adenosine monophosphate. This results in smooth muscle relaxation, mast cell membrane stabilization, and skeletal muscle stimulation. 2. Aerosol administration enhances bronchoselectivity and provides a more rapid response and greater protection against provocations that induce bronchospasm, e.g., exercise, or allergen challenges, than does systemic administration. 3. Albuterol and other inhaled short-acting selective beta-2 agonists are indicated for treatment of intermittent episodes of bronchospasm and are the first treatment of choice for acute severe asthma and exercise-induced bronchoconstriction. Regular treatment, that is 4 times daily, does not improve symptom control over as needed use. 4. Formoterol and salmeterol are inhaled long-acting beta-2 agonists indicated as adjunctive long-term control for patients with symptoms who are already on low to medium doses of inhaled corticosteroids prior to advancing to medium or high-dose inhaled corticosteroids. Short-acting beta-2 agonists should be continued for acute exacerbations. Long-acting agents are ineffective for acute severe asthma because it can take up to 20 minutes for onset and 1 to 4 hours for maximum bronchodilation after inhalation. 5. In acute severe asthma, continuous nebulization of short-acting beta-2 agonists, e.g., albuterol, is recommended for patients having an unsatisfactory response after 3 doses, every 20 minutes, of aerosolized beta-2 agonists and potentially for patients presenting initially with peak expiratory flow or FEV1 values less than 30% of predicted normal. Dosing guidelines are presented in Table 82. 6. Inhaled beta-2 agonists agents are the treatment of choice for exercise-induced bronchoconstriction. Short-acting agents provide complete protection for at least 2 hours after inhalation. Long-acting agents provide significant protection for 8 to 12 hours initially, but the duration decreases with chronic regular use. 7. In nocturnal asthma, long-acting inhaled beta-2 agonists are preferred over oral sustained-release beta-2 agonists or sustained-release theophylline. However, nocturnal asthma may be an indicator of inadequate anti-inflammatory treatment. Pause the video and carefully scrutinize Figure 81 illustrating a stepwise approach for managing asthma in adults and children aged 5 years and older before advancing to the next slide. Pause the video and carefully scrutinize Figure 81 illustrating a stepwise approach for managing asthma in adults and children aged 5 years and older before advancing to the next slide. Pause the video and carefully scrutinize Figure 82 illustrating home management of acute asthma exacerbation before advancing to the next slide. Pause the video and carefully scrutinize Table 81 summarizing relative selectivity, potency, and duration of action of the beta-adrenergic agonists before advancing to the next slide. Pause the video and carefully scrutinize Table 82 summarizing dosages of drugs for acute severe exacerbations of asthma in the emergency department or hospital before advancing to the next slide. Pause the video and carefully scrutinize Table 83 summarizing available inhaled corticosteroid products, lung delivery, and comparative daily dosages before advancing to the next slide. Next we will focus on corticosteroids. 1. Corticosteroids increase the number of beta-2 adrenergic receptors and improve receptor responsiveness to beta-2 adrenergic stimulation, thereby reducing mucus production and hypersecretion, reducing bronchial hyperresponsiveness, and reducing airway edema and exudation. 2. Inhaled corticosteroids are the preferred long-term control therapy for persistent asthma in all patients because of their potency and consistent effectiveness. They are also the only therapy shown to reduce the risk of death from asthma. Comparative doses are included in Table 83. Most patients with moderate disease can be controlled with twice-daily dosing. Some products have once-daily dosing indications. Patients with more severe disease require multiple daily dosing. Because the inflammatory response of asthma inhibits steroid receptor binding, patients should be started on higher and more frequent doses and then tapered down once control has been achieved. The response to inhaled corticosteroids is delayed. Symptoms improve in most patients within the first 1 to 2 weeks and reach maximum improvement in 4 to 8 weeks. Maximum improvement in FEV1 and peak expiratory flow rates may require 3 to 6 weeks. 3. Systemic toxicity of inhaled corticosteroids is minimal with low to moderate inhaled doses, but the risk of systemic effects increases with high doses. Local adverse effects include dose-dependent oropharyngeal candidiasis and dysphonia, which can be reduced by the use of a spacer device. The ability of spacer devices to enhance lung delivery is inconsistent and should not be relied on. 4. Systemic corticosteroids, shown in Table 84, are indicated in all patients with acute severe asthma not responding completely to initial inhaled beta-2 agonist administration, every 20 minutes for 3 to 4 doses. Prednisone, 1 to 2 mg per kilogram per day, that is up to 40 to 60 mg per day, is administered orally in 2 divided doses for 3 to 10 days. Because short-term, lasting 1 to 2 weeks, high-dose systemic steroids do not produce serious toxicities, the ideal method is to use a short burst and then maintain the patient on appropriate long-term control therapy with inhaled corticosteroids. 5. In patients who require chronic systemic corticosteroids for asthma control, the lowest possible dose should be used. Toxicities may be decreased by alternate day therapy or high-dose inhaled corticosteroids. Pause the video and carefully scrutinize Table 84 summarizing comparison of the systemic corticosteroids before advancing to the next slide. Let's now discuss methylxanthines. 1. Theophylline appears to produce bronchodilation by inhibiting phosphodiesterase, which may also result in anti-inflammatory and other non-bronchodilator activity through decreased mast cell mediator release, decreased eosinophil basic protein release, decreased T lymphocyte proliferation, decreased T cell cytokine release, and decreased plasma exudation. 2. Methylxanthines are ineffective by aerosol and must be taken systemically, that is orally or IV. Sustained-release theophylline is the preferred oral preparation, whereas its complex with ethylene diamine, also called aminophylline, is the preferred parenteral product due to increased solubility. IV theophylline is also available. 3. Theophylline is eliminated primarily by metabolism via hepatic cytochrome P450 mixed-function oxidase microsomal enzymes, primarily CYP1A2 and CYP3A4, with 10% or less excreted unchanged in the kidney. The hepatic cytochrome P450 enzymes are susceptible to induction and inhibition by various environmental factors and drugs. Clinically significant reductions in clearance can result from co-therapy with cimetidine, erythromycin, clarithromycin, allopurinol, propanolol, ciprofloxacin, interferon, ticlopidine, xiluten, and other drugs. Some substances that enhance clearance include rifampin, carbamazepine, phenobarbital, phenytoin, charcoal broiled meat, and cigarette smoking. 4. Because of large interpatient variability in theophylline clearance, routine monitoring of serum theophylline concentrations is essential for safe and effective use. A steady-state range of 5 to 15 micrograms per milliliter is effective and safe for most patients. 5. Figure 83 gives recommended dosages, monitoring schedules, and dosage adjustments for theophylline. 6. Sustained-release oral preparations are favored for outpatient therapy, but each product has different release characteristics and some products are susceptible to altered absorption from food or gastric pH changes. Preparations unaffected by food that can be administered a minimum of every 12 hours in most patients are preferable. 7. Adverse effects include nausea, vomiting, tachycardia, jitteriness, and difficulty sleeping. More severe toxicities include cardiac tachyarrhythmias and seizures. 8. Sustained-release theophylline is less effective than inhaled corticosteroids and no more effective than oral sustained-release beta-2 agonists, cromolyn, or leukotriene antagonists. 9. The addition of theophylline to optimal inhaled corticosteroids is similar to doubling the dose of the inhaled corticosteroid and is less effective overall than the long-acting beta-2 agonists as adjunctive therapy. Pause the video and carefully scrutinize Figure 83, which is an algorithm for slow titration of theophylline dosage and guide for final dosage adjustment based on serum theophylline concentration measurement before advancing to the next slide. And now we will shift gears to anticholinergics. 1. Ipratropium bromide and tiotropium bromide are competitive inhibitors of muscarinic receptors. They produce bronchodilation only in cholinergic-mediated bronchoconstriction. Anticholinergics are effective bronchodilators but are not as potent as beta-2 agonists. They attenuate, but do not block, allergen or exercise-induced asthma in a dose-dependent fashion. 2. The time to reach maximum bronchodilation from aerosolized ipratropium is longer than from aerosolized short-acting beta-2 agonists, that is 30 to 60 minutes versus 5 to 10 minutes. This is of little clinical consequence because some bronchodilation is seen within 30 seconds and 50% of maximum response occurs within 3 minutes. Ipratropium bromide has a duration of action of 4 to 8 hours. Tiotropium bromide has a duration of 24 hours. 3. Inhaled ipratropium bromide is only indicated as adjunctive therapy in severe acute asthma not completely responsive to beta-2 agonists alone, because it does not improve outcomes in chronic asthma. Tiotropium bromide has not been studied in asthma. We will now progress to mast cell stabilizers. 1. Cromolyn sodium and nedocromyl sodium have beneficial effects that are believed to result from stabilization of mast cell membranes. They inhibit the response to allergen challenge as well as exercise-induced bronchoconstriction, but do not cause bronchodilation. 2. These agents are effective only by inhalation and are available as metered dose inhalers. Cromolyn also comes as a nebulizer solution. 3. Both drugs are remarkably non-toxic. Cough and wheezing have been reported after inhalation of each agent, and bad taste and headache after nedocromyl. 4. Cromolyn and nedocromyl are indicated for the prophylaxis of mild persistent asthma in children and adults regardless of etiology. Their effectiveness is comparable to theophylline or leukotriene antagonists for persistent asthma. Neither agent is as effective as inhaled corticosteroids for controlling persistent asthma. Neither is as effective as the inhaled beta-2 agonists for preventing exercise-induced bronchoconstriction, but they can be used in conjunction for patients not responding completely to inhaled beta-2 agonists. 5. Most patients experience improvement in 1 to 2 weeks, but it may take longer to achieve maximum benefit. Patients should initially receive cromolyn or nedocromyl 4 times daily. After stabilization of symptoms, the frequency may be reduced to 2 times daily for nedocromyl and 3 times daily for cromolyn. And now we will focus on leukotriene modifiers. 1. Zafirlukast, marketed as Accolate, and Montelukast, marketed as Singulair, are oral leukotriene receptor antagonists that reduce the pro-inflammatory, increased microvascular permeability and airway edema, and bronchoconstriction effects of leukotriene D4. In adults and children with persistent asthma, they improve pulmonary function tests, decrease nocturnal awakenings and beta-2 agonist use, and improve asthma symptoms. However, they are less effective in asthma than low-dose inhaled corticosteroids. They are not used to treat acute exacerbations and must be taken on a regular basis, even during symptom-free periods. The adult dose of Zafirlukast is 20 mg twice daily, taken at least 1 hour before or 2 hours after meals. The dose for children aged 5 through 11 years is 10 mg twice daily. For Montelukast, the adult dose is 10 mg once daily, taken in the evening without regard to food. The dose for children aged 6 to 14 years is 1 5 mg chewable tablet daily in the evening. 2. Zafirlukast and Montelukast are generally well tolerated. Rare elevations in serum aminotransferase concentrations and clinical hepatitis have been reported. An idiosyncratic syndrome similar to the Churg-Strauss syndrome, with marked circulating eosinophilia, heart failure, and associated eosinophilic vasculitis, has been reported in a small number of patients. A direct causal association has not been established. 3. Xileuton, marketed as Zyflo, is an inhibitor of leukotriene synthesis. The dose of Xileuton tablets is 600 mg 4 times daily with meals and at bedtime. The recommended dose of Xileuton extended-release tablets is 2 600 mg tablets twice daily, within 1 hour after morning and evening meals. That is a total daily dose of 2,400 mg. 4. Use of Xileuton is limited due to the potential for elevated hepatic enzymes, especially in the first 3 months of therapy, and inhibition of the metabolism of some drugs metabolized by CYP3A4, e.g., theophylline, and warfarin. Serum alanine aminotransferase should be monitored before treatment and then periodically thereafter. Next we will discuss combination controller therapy. 1. The addition of a second long-term control medication to inhaled corticosteroid therapy is one recommended treatment option in moderate to severe persistent asthma. 2. Single inhaler combination products containing fluticasone propionate and salmeterol, marketed as Advair, or budesonide and formoterol, marketed as Symbicort, are currently available. The inhalers contain varied doses of the inhaled corticosteroid with a fixed dose of the long-acting beta-2 agonist. The addition of a long-acting beta-2 agonist allows a 50% reduction in inhaled corticosteroid dosage in most patients with persistent asthma. Combination therapy is more effective than higher-dose inhaled corticosteroids alone in reducing asthma exacerbations in patients with persistent asthma. 3. Leukotriene receptor antagonists also are successful as additive therapy in patients inadequately controlled on inhaled corticosteroids alone and as corticosteroid-sparing therapy. However, the magnitude of these benefits is less than that reported with the addition of long-acting beta-2 agonists. And now we will briefly look at omalizumab. 1. Omalizumab, marketed as Xolair, is an anti-IgE antibody approved for the treatment of allergic asthma not well controlled by oral or inhaled corticosteroids. The dosage is determined by the patient's baseline total serum IgE, international units per milliliter, and body weight, in kilograms. Doses range from 150 to 375 mg given subcutaneously at either 2 or 4-week intervals. 2. Because of its high cost, it is only indicated as Step 5 or 6 care for patients who have allergies and severe persistent asthma that is inadequately controlled with the combination of high-dose inhaled corticosteroids and long-acting beta-2 agonists. 3. Because it is associated with a 0.1% incidence of anaphylaxis, patients should remain in the physician's office for a reasonable period after the injection because 70% of reactions occur within 2 hours. Some reactions have occurred up to 24 hours after injection. Let's now discuss evaluation of therapeutic outcomes. We will begin with chronic asthma. 1. Control of asthma is defined as reducing both impairment and risk domains. Regular follow-up is essential, at 1 to 6 month intervals, depending on control. 2. Components of the assessment of control include symptoms, nighttime awakenings, interference with normal activities, pulmonary function, quality of life, exacerbations, adherence, treatment-related adverse effects, and satisfaction with care. The categories of well-controlled, not well controlled, and very poorly controlled are recommended. Validated questionnaires can be administered regularly, such as the Asthma Therapy Assessment Questionnaire, Asthma Control Questionnaire, and Asthma Control Test. 3. Spirometric tests are recommended at initial assessment, after treatment is initiated, and then every 1 to 2 years. Peak flow monitoring is recommended in moderate to severe persistent asthma. 4. Patients should also be asked about exercise tolerance. 5. All patients on inhaled drugs should have their inhalation technique evaluated monthly initially and then every 3 to 6 months. 6. After initiation of anti-inflammatory therapy or an increase in dosage, most patients should begin experiencing a decrease in symptoms within 1 to 2 weeks and achieve maximum symptomatic improvement within 4 to 8 weeks. Improvement in baseline FEV1 or peak expiratory flow should follow a similar time frame, but a decrease in bronchial hyperresponsiveness as measured by morning peak expiratory flow variability, and exercise tolerance may take longer and improve over 1 to 3 months. Finally, we will discuss acute severe asthma. 1. Patients at risk for acute severe exacerbations should monitor morning peak flows at home. 2. Lung function, either spirometry or peak flows, should be monitored 5 to 10 minutes after each treatment. 3. Oxygen saturations can be easily monitored continuously with pulse oximetry. For young children and adults, pulse oximetry, lung auscultation, and observation for supraclavicular retractions is useful. 4. Most patients respond with the first hour of initial inhaled beta agonists. Patients not achieving an initial response should be monitored every 0.5 to 1 hour. Thank you.